Today's lecture is going to be about the opiates and pharmacogenetics and understanding the risk that genetics can impose upon opiate use. Opiates are a huge societal problem in the United States. Currently, opiates have made adverse drug reactions the third leading cause of death in the United States. A lot of this has to do with the introduction of very potent synthetic opiates like fentanyl. And I'm going to talk about how some of the genetics affects your risk of dying from an opiate overdose. Currently, 107,000 Americans died in 2021 from opiate overdoses. There are two genes that affect opiate safety and efficacy. The first one we'll talk about is OPRM1. Now, OPRM1 is the gene that encodes for the mu-opiate receptor, and that's the receptor through which opiate analgesics produce their effects, and unfortunately also produce their exaggerated effects, which lead to overdose. So activation of this receptor by an opiate, such as morphine, causes all the effects we normally associate with opiates, such as sedation, analgesia, reduced blood pressure, and respiratory depression, one of the leading causes of death due to opiate overdose. Now, there's a particular polymorphism or mutation in this opiate receptor called the A118G polymorphism. It's present in about 20% of the population, so it's not uncommon. 1 in 5 people have this mutation. And if you have this mutation, then you don't respond very well to opiates, mostly because you don't express very many of these opiate receptors in order to pick up an opiate signal. Patients that have this also have a lower pain threshold, and they have to take much higher doses of an opiate to get an effect, if they get much of an effect at all. Interestingly, this same mutation results in a gain of function or increased function in the endogenous opiate system, like the beta endorphins. And that affects how naltrexone affects alcoholism treatment. So if you have this mutation, naltrexone works better for you. In fact, if you don't have the mutation, naltrexone is not very effective for alcoholism treatment. But the main result we're going to look at for this mutation is its effect on opiates themselves and how they affect the response to opiates for treatment of pain, as well as the risk of overdose. So why would we want to learn about your genetics for opiates so that we can better treat you? So one of the things that happens is that this particular mutation in the OPRM1 gene increases the sensitivity of the mesolimbic dopamine reward pathway. And what happens is that it results in a decrease in dopamine release in these reward pathways. That leads to an increase in the need for higher doses to produce a euphoric effect. And what that leads to is addiction. And this also increases the addiction risk to other drugs as well, not just the mu opiates, but also heroin, cocaine, alcohol, all these others that also stimulate these reward pathways and lead to their addictive properties. Now, unfortunately, this same mutation, even though it decreases the response to opiate activity, increases the death from opiate overdose 91-fold. And the reason for this is that the high affinity opiates like heroin and fentanyl aren't affected by this mutation. So people will start off taking oral opiates prescribed by their doctor, get addicted, have to take huge amounts because of this mutation. And then when they switch over to fentanyl, either illicitly or prescribed by their physician, the dose that they're prescribed based on their previous opiate intake is wrong, and they end up overdosing, and it increases their risk of dying. Now, one of the things about this is that, again, the normal oral opiates that are moderate affinity are decreased in your ability to respond to them by this mutation, which doesn't affect the high affinity. So when you switch over, essentially, you overdose on what we consider the normal transition dose. Now, another gene that's important in the safety and efficacy of opiate have to do with metabolism of the opiates. So a lot of the oral opiates that you take are what we call codon drugs. They're essentially a codeine or codon structural pathway that's inactive. And then when it goes through your liver, this enzyme called cytochrome P450-2D6 converts the inactive opiate like codeine into its active form, which is the morphone form. And for codeine, that morphone form would be morphine. So what we're looking at is the enzyme that takes an inactive drug that you take, the pill, and converts it to its active form. Unfortunately, cytochrome P450-2D6, the gene that codes for that CYP2D6, is highly variable. So what happens is that you don't only half the population have normal 2D6 function. So only half the population can convert these codone derivatives into their active morphone metabolites. Now, while half the people are normal, about half of them do not convert the active morphine metabolites at all. In other words, they have a mutation in the CYP2D6 gene that leads to impaired function of cytochrome P450-2D6 enzyme. Now, that means that they do not convert to the active form, therefore they don't get therapeutic benefit from the opiate. Now, about 2% of the population exhibit ultra-rapid metabolism, and they convert to the active form too quickly. And that results in excessive concentrations of the active metabolite, and they can overdose on a normal therapeutic dose of a codone. Here's a case study, and this shows you how important this is. Luckily, in this case, the patient did not die. This is a 62-year-old male with leukemia and pneumonia, and he was treated with an antibiotic, voriconazole, an antifungal, and codeine, which is the codone form of the opiate, for his cough. Normal, typical dose for cough. However, at the fourth day, the patient kept going down. They ended up in coma and respiratory failure, requiring to be put on a ventilator and kept in the ICU. Now, we know that they resolved this issue by giving naloxone, which is an opiate blocker. So they treated them for opiate overdose, and the symptoms resolved. After that, they did a pharmacogenetic test to find out what might have happened, and they found out that they were CYP2D6 ultra-rapid metabolizer. Therefore, they were converting to morphine very, very rapidly. And so there's another pathway which codeine goes through to an inactive metabolite called norcodeine. They essentially didn't metabolize through that pathway. So all of it was going through 2D6 in an ultra rapid manner. They found that their morphine values in the blood for this patient were 20 to 80-fold higher than you would have expected from the normal codeine dose that they gave them. And of course, these morphine metabolites resulted in renal failure as well. So they ended up having kidney failure as well. But luckily, they were able to resolve this by giving a opiate blocker, naloxone, and the patient recovered. So another group of patients that this is really important for happen to be with infants and young people, essentially grade school kids. And what happened, the first case here is an ultra-rapid metabolizer for 2D6. The mother was given codeine for episiotomy pain. What happened is that morphine is secreted in breast milk. So what happened is that this ultra-rapid metabolizer created all this morphine. It gets excreted in the breast milk. The baby suckling at the breast ends up dying from a morphine overdose because of the mother's 2D6 ultra-rapid metabolism. There are other examples here. Most of them have to do with tonsillectomy, things you typically think a young kid would undergo, and dealing with pain associated with that. Given normal codeine doses, they either ended up in a serious condition or death. And that's, that's horrible. That's a horrible thing. And we could avoid this if we had known that the kid or the mother was a 2D6 ultra rapid metabolizer. So these mutations can have horrible, catastrophic, tragic effects in both in the patients and in the case of the newborn suckling, in the child of the mother. And if we just known that their 2D6 ultra rapid metabolizer status, then we could have avoided the death and serious injury to these children. So it's very important for opiates to understand your pharmacogenetics, just from the safety as well as whether they're going to work for you or not. So thank you for listening to this installment. There'll be another lecture in this series in the next month or so. Thank you so much, and look forward to seeing you in the future.